Yes. People are joining right now, so welcome everybody as you link in to hear a really interesting presentation and discussion on part of our Triple Crown Cancer Care series that we're working on for since this entire year. And this particular webinar today is about the third that we have in our series. We've had several in-person programs on different aspects of the cancer care journey. And we'll continue to have a cancer care symposium, but I'll tell you about that in a minute. But the whole idea for the cancer care series, Triple Crown series, is number one, we started it in spring, which had the Triple Crown and has a nice little racehorse on it as well. So we thought that was a fitting theme. And then the real focus is on accessible, affordable, and exceptional care. Those are the three parts of the Triple Crown for us, and rather than being locations like Kentucky or Belmont or other places, Belmont. So those are the three key areas that most employers are very concerned about. Cancer care is their highest cost of most employers, and probably getting more and more expensive simply because of the new treatments that are coming on board. So. But it's more than just the treatment. Cancer covers a variety of the patient journey, which we'll talk about today, from risk identification to survivorship, and all of which is improving cancer care outcomes across the full patient journey. So today's discussion is going to be part of that risk identification to survivorship today. And let me go to the next slide and tell about a few upcoming programs. Before I recognize our sponsor here, I'll recognize our sponsors now. We're very, very pleased to have support for this whole Triple Crown Cancer Care series from Color, which is Danny, our speaker today. Mata is from Color. Genentech, Genomic Life, McKesson, Merck, and Pfizer are all key sponsors of the entire series. Like I said, several in-person programs as well as the webinars on different aspects of the cancer care journey, and then the final one on the symposium. So next slide. Let me mention about the Cancer Care Symposium. It's a half-day program on September 23rd, and at the DoubleTree near the Galleria. And you all are invited to participate in that. We've got a panel of speakers, all in different aspects of the cancer care journey. So from navigation to treatment, to the pharmacy side of it, to the return to work side of it, and of course from the prevention and initial diagnosis. So it's covering the whole waterfront of the cancer care journey. And again, the focus is always on the accessible, affordable, and exceptional care. So mark your calendars, you're invited. Another upcoming event is on October 21st. This is one of our regular luncheon programs. This one is going to talk about Beyond the Dashboard, a fresh look at detecting fraud, waste, and abuse through data analytics. Again, at the DoubleTree near the Galleria, that'll be a regular luncheon program, 11:30 to 1:30, plenty of time for networking, and also time to listen to a really strong program with our speakers. And then I think we have in this, the grand finale of the year is our employer roundtable, which starts at the beginning of our Casino Royale Betting Big on Benefits. This is employer-only roundtable that takes place in the morning of December 2nd, which is the first day of our Casino Royale Betting Big on Benefits, which goes through the December 2nd and December 3rd. And this is a chance for employers to coverage, talking about GLP-1 specifically, coverage, which doesn't have to be an all or nothing decision. That's another one of the high costs for employers who are covering GLP-1s. So please mark that on your calendar. And right after that roundtable for employers only will be our big annual conference of the year annual forum. Again, same thing, same theme. Betting Big on Benefits, our 22nd annual forum. And this is in the afternoon of December 2nd. That's a Tuesday or Wednesday. And the all day of December 3rd. with sessions all day and sponsors and a big casino party on the evening of December 2nd. And you know that a lot of guys are going to be wearing their tuxes, and there's going to be plenty of people wearing their glamour dresses for Casino Royale, just like at Monte Carlo. If you've never been there, which I have actually, it's pretty spectacular. So that'll be a great celebration, and please mark the calendars for that as well. All of our corporate members can attend any of our programs complimentary. So if you're an employer that's thinking about joining the Dallas-Fort Worth Business Group on Health, please go ahead and join. It will be very access to all of these programs is complimentary, and we're always welcoming new sponsors. We have several ways to connect with us. You can do LinkedIn, obviously, and then you can do a YouTube program where we have a little program, a video called Fault Line. So take a look at that. And now let me go ahead and introduce our speaker for today. This is Danny Maltar. He's the Chief Operating Officer of Color, one of our sponsors, a key sponsor for today's program. He focuses on delivering Color's promise of outstanding experience and outcomes to customers and patients. He's had plenty of experience in working with the government, with healthcare agencies, and life science clients when he was a consultant at McKinsey & Company. He's also a physician by training and holds a master's degree in public health from Johns Hopkins University. And he said he lived in Austin for a while when he was working with some of the agencies, healthcare related agencies there. So he knows what Texas is like and what the how our weather is, which he's really happy he's not living here now during 104 degrees. So Danny, questions and responses. If you'll hold your questions, you place your questions, but Danny will respond to them at the end of his discussion. He's got a great presentation. So please go ahead through the Q&A portal and submit your questions about any part of it that he's discussing for. So he's going to talk about Care for Cancer Reinvented, a major key part of our cancer, Triple Crown cancer care experience.
Thanks a lot, Marianne, and thank you for hosting us on this, and thanks for all who joined too. I may have met some of you when we were in person in one of our workshops earlier this year, but I'm looking forward to talking here more about our work. I'm going to share my screen, and then we can go through the presentation. Let me just put it in slideshow, and then Marianne, can you all see my screen or anyone from the... All right, great. I see nods. So we'll talk a little bit about cancer, and what I thought could be helpful is share a bit of context of like what we're seeing and why we're seeing the problems you're all seeing in your own data on cancer. Obviously, cancer is a major spend right now for all employers and many of our customers and partners we work with. It's a problem in your population. It is a top cost. And what I want to share with you a little bit is maybe three parts. One, why this is happening. What can you do about it? And also an example, a real example from one of the programs we work with or customers we work with on how what success can look like and what you can hope to achieve if you do this right or if you address this the right way. I'll skip the intro. I think Marianne gave an intro myself. I think in my role, what I would just add is in my role, I do make sure the promise we give to you and to your own members and to your own patients is actually delivered. That's what I make sure we do every day, and that's my work. And I spend a lot of time working with many of our customers on making sure the program is successful and seeing that in their outcomes and their claims. I thought what's most helpful for us is to start by talking about why this is happening and why you're seeing this sudden increase in trend in cancer, and may see it as a problem in your population. We call it the triple wave, but basically there's three main trends that happened over the past 50 years that are driving the impact you're seeing today. One is cancer is impacting younger populations. Actually, the incidence is increasing generally for cancer, but also more importantly, it's happening younger at younger ages. And actually, in the past 50 years, 14 cancers have had an increase in incidence among the people under 50. So, and that's why you're starting to see it more and more in the working population and in your own data as well. The second main trend that also happened at the same time is we're having an explosion in actual treatment options and treatment innovation when it comes to cancer. And if anything, there hasn't been a more hopeful time than today for patients who have cancer because they have much, much better treatment options. They're more effective. They actually also have less side effects, but they're coming with maybe two implications. One, a higher price tag. So if you actually look at the data of the, brief most recent drugs that the FDA has approved for cancer, like more than 90% of those drugs are actually costing more than $100,000 a year. So the cost of the treatment is becoming higher. And so the stakes are higher when you're having to pay more and making sure, that treatment is successful. The second thing is it's also making the treatment protocols more complex. So if you think about in the past, we used to say, somebody who has breast cancer is a stage 2 breast cancer patient. There's a first line of therapy, then a second line, and a third line, and you go through those as a patient. Today, this is more complex, depending on the profile of the tumor, the markers on that tumor, the genetic markers. The treatment is different, and actually, there's more effective treatments that are a lot more targeted that have less side effects but are more effective on the tumor itself. But it means that now the treatment protocols are more complex and nuanced. And what we're seeing in our own patients and with our own data is the system that is having a hard time catching up on that. I think every year, like treatment protocols change uh, very frequently right now. Like in the past month, we've had two, three, four new drug approvals that are actually impacting better care for cancer patients. So when it becomes more complex and the system has not been set up to manage that effectively, you start seeing more gaps in the system and more gaps in treatment and worse outcomes for patients. That also translates into higher costs for you all. So that's the second wave. And then the third is because treatment is getting better, you have more and more patients actually, living longer with cancer or after their cancer treatment. And actually, in your own workforce, you probably have 10 times more people who are cancer survivors than actually people who are undergoing cancer treatment. So that's a growing population. It's a population that has complex needs and complex care needs, uh, be it from the long-term side effects of their treatment, the actual complications from their treatment. They're probably on maintenance therapy that is expensive for them from another pocket cost standpoint and for the plan as well. And they need more complex care management. But the problem there too is that like the system is not set up for that. So both from a capacity standpoint, the demand is far outpacing the supply of physicians coming and supporting the patients, but also there's no real specialty in survivorship or in cancer survivorship. So there's no training for it specifically. So when patients go back to their PCPs, they're not a normal regular profile patient, they're more complex, but there's no training also to equip the workforce to support those patients well. And if you think about those three like trends, they're actually like compounding an impact for you all because you have more patients getting cancer earlier, they're on more expensive treatment and they require more complex care, and they're surviving longer and require more support long term. And so that's what you're seeing basically and that's what's amounting to what you're seeing in your own data and in your own plans of we're having higher increasing cost and a more complex population that we're having to manage. And that's sort of the implication. So that's what's happening. And that's basically the trends are bringing that here. And I'm also talking about the trends because this is something that's meant to continue over time. Those trends are continuing. We have more treatments coming that are effective. We still don't know what's driving cancer to happen earlier. And so we're going to continue seeing that incidence be high in earlier populations. And obviously the survivorship population is growing. Um, in that context, let's talk a little bit about what you can do about it. And I actually think what's been interesting here for me, speaking with many of our, health plan leaders and benefit leaders, I think the most common thing I hear is this tension between how can I manage my costs, but also keep doing right by my members? We want our members and everybody to get the best cancer care. And it feels like there's this tension between those two, or you have to trade off between those two. And the most common story I hear is about, those high cost claimants that you see in your own data that have probably blown through your budget every year, and people feeling they don't really have a grasp or what should they do differently to prevent those from happening or not have them happen in the future. And because they're very unique too. If you look at your high cost claimants, typically you see different types of them, different reasons for those. And so it's been a challenge that's been the common challenge I hear. What I'm here to say, and probably the biggest takeaway I would say is like actually you don't have to trade off between those two things. And you'll see a little bit in the presentation too, like actually when you drive the right impact for patients, it's going to have a meaningful impact on your costs. And I'll talk a little bit about how you do that. And I'll show you how in a real example. And going a little bit deeper, one thing we did is we went back and looked at the cost data and the high cost data and claims data for our customers. And what's interesting is actually there's more, if you look at your high cost claimants and who have cancer, in cancer specifically, what's interesting is when we look at the data ourselves, like roughly two-thirds of those, we see signs in the claims of the patients that actually like the cost could have been prevented in some way. And for those two-thirds where the high cost claim could be prevented, what's interesting is they all fall into one of these five buckets that I have on this slide, and I'll talk about each bucket there in a little bit more detail. And the first bucket is, we see cancers that are late stage that are screenable and could have been caught earlier. And when we walk back what happened to the patient, we see that the screening had not happened or there's a missing screening claim in the past. So it's a screenable cancer or preventable that could have been diagnosed early, would have not. That's one bucket of high cost claimants we see. The second bucket of high cost claimants we see is patients who um, uh, have had an insufficient or incomplete diagnostic workup, and that resulted in a suboptimal treatment. And I shared a little bit when I talked about the trends that, today for many of the cancers, there's specific tumor markers that are recommended to be done during the workup, and those impact the treatment that the patient is on. And sometimes if a tumor marker is found, there's a likely much better and more effective treatment with less side effects that the patient could take. So when those are not done in the workup, there's likely a missed opportunity for the patient to be on the right treatment. And when we trace back again, in the claims, you can see some of those signals, like a missing workup or a change in the treatment going, and then where they went back to the original one when it was needed. And so those gaps could have prevented a worse, because if you're on a suboptimal treatment that has more side effects, you're going to have to pay more for the care of the patient, but also at some point the treatment is going to fail. They're going to go to another one. They're going to go to another one. So that's another core bucket of opportunity we see. The third is the treatment plan itself being inappropriate or missing key parts or in terms of like dosage or the right drug or the right protocols. We also see some of those gaps, and those end up also driving higher costs. The fourth is symptoms and palliative care support. Today, there's actually a lot of evidence of how this is critical for the care of the patient, not just from a supportive sense, but also it increases the likelihood that the actual treatment is successful. It increases the likelihood that the patients stay on their treatment if the symptoms are managed. And often those are the symptoms that drive a very bad outcome, like somebody getting admitted to the ICU and having, both a worse outcome for them, which also impacts cost. And so that's another flavor of what we see in the claims data. And when you trace those back, you see that some of the palliative care support was not there or was not documented. You don't find it in the patient's journey, and then you see the high cost happening at the end of them going to the ED or to the hospital in the ICU. And the fifth one, which is also a very common thing we see and we hear from customers, it's a very expensive treatment. It could have been delivered at a lower cost, but it is not, for whatever reason, either it's because the site specifically is more expensive, or there's a biosimilar version, but the brand was given, and we also see that in the data. So to recap, when we looked at our high cost claims and where there could be a difference, they all fall into one of these five buckets. And actually, if you add up like the savings opportunity, when you look at those, um, roughly, like, the addressable opportunity is actually pretty big. You could save 20 to 30% of your total cancer spend if you actually had a way to prevent these events from happening, basically. And that's a big opportunity. And the other common thing, if you look at all five of them, is it's actually a clinical decision point that had to happen at some point in the care of the patient that happened incorrectly or in a different way. And that if that was done differently, could have prevented that cost from happening. And that's what my point on. It's not a trade-off between necessarily the quality of the care and the cost of the care. If anything, if the right clinical decisions happen, there's this meaningful savings opportunity for the plan. And that's what we estimate basically when we look at the claims data for our customers. So that's sort of the opportunity here, and that's how we've been seeing it, and that's how it maps to what you all are seeing as well in your own claims data, and in your own stats basically, and within your own population. So that's the setup. That's what we're going to talk about. I'm going to go through, before I go through like an example actually of how this looks like, and also talk a little bit about how we do it. I want to take a pause and maybe do a quick poll from you all. If you look at the five buckets that I've shared here, I'd love to hear from you all, like which of these five issues have you've seen in your own data as a high cost claim. And you probably have seen many of them, but I'm curious which ones go top of mind for you, you've seen more often of. So I'll give you all a minute to fill the poll, and then we can continue through the presentation. We're at the minute mark. I'm seeing, if the third respondent of the response answered. I'm looking at the data. I mean, uh, this is pretty on par with what we see also in our own data, in terms of cancer, like late cancers being like a big driver, and then roughly another 40-50% where you see either a diagnostic workup that's incomplete, or a treatment plan that's ineffective, or symptoms that are not managed, and 50% on the side of care. I think this is typically what we've also been seeing, or what I hear. And again, also the common thing is, these don't add to 100, so you all are seeing probably multiple ones of them, which is actually also consistent. Uh, Let me talk a little bit now about basically just and I want to set that context before I just introduce color. I think some of you may know color, but I want to make sure you have context on what color does, and how it ties to what I shared before on like the trends you're seeing and the problems you're seeing. So uh, uh, as I mentioned, all these five scenarios are scenarios where if you had better clinical decisions or different clinical decisions, they would not have happened. And we do think that that's actually a tool that, can actually make a meaningful impact, both in making sure patients have the right outcome and also in making sure your costs are well managed. And if you think about it from today, there's nothing preventing us with the current technology and with the current tools we have to make sure every patient, no matter where they live or what their cancer is, or what they have, or what their diagnosis is, there's nothing preventing us from making sure that patient gets the right care at every single point in time, because that expertise and that knowledge and that evidence is out there. It exists. It exists with the experts and leading experts in the country. It exists with guidelines and evidence and research and the trials that are happening. So there's no reason why preventing us today from offering that to all patients across the country. And that's sort of the thesis through which Color Health is trying to work with everyone. We're basically a virtual cancer clinic, and as a virtual cancer clinic, we deliver cancer care across all 50 states to all patients, and we support patients across the full journey. So from how they get diagnosed, they prevent or catch cancer early and get diagnosed early, to their cancer care and treatment journey, to survivorship care after they complete their treatment. We deliver care across all 50 states. The medical group has a multidisciplinary team of oncologists, oncology nurses, physicians, cancer experts, cancer dietitians, care advocates, cancer risk experts, and their role is to work with our patients directly as one of their core providers to make sure that those right outcomes happen across the full journey. And that's the model we work with our customers on, and it allows to make sure, and it allows us to sort of be that clinical layer that is trying to make sure that the right decisions are happening within your plan design for every one of the patients across the country. And the last thing I'd add before I go to the example is Color is certified by the American Society of Clinical Oncology, or ASCO. ASCO is the standard setter, like they set the standards for the best practice cancer care in the country, and including things like how do you make sure you have multidisciplinary care, how you make sure patients get palliative care, they get access to clinical trials. We went through that certification ourselves because we believe you can deliver that quality of care today to all patients across the country. And it's also the way we keep ourselves honest, and somebody keeps us honest on whether we're delivering that care for the patients that we support. And through this model, we can help employers basically address these five causes I mentioned at the beginning. I'm going to talk about an example customer, and I think I felt like that's probably the easiest way to speak through how a program can work to address these failure points in the system, and then how that translates to better outcomes and better costs in the system when you do that. So the example I'm sharing here is one of our actual customers. They're a global power management company, 34,000 covered lives. They have a distributed, obviously, workforce, pretty diverse. It's a shift-based workforce. They're across multiple locations, and we've been live with them now for a bit more than a year. And similar to many of you, cancer was one of their top healthcare spend. Again, as I mentioned, their workforce is pretty shift-based. It's also remote and in places where it's harder to access healthcare services. And that was a common challenge they've had and they've had to face. And They do have good plan coverage, like probably many of you do, but it's been hard to actually get the outcomes happen through the coverage they've been doing. And so we've been with them live for a year, and we've worked with them on implementing a program that tries to address all of the components of their cancer problem to see how we can change some of those outcomes. And I'll speak to how we've done that together. Here's an overview of the overall population outcomes we've seen after a year of this program being live. This is in the first year of the program, and basically that all this happened. And I'll click through each one of the components in more detail, but just to give you a snapshot. So we engage and work with more than 20% of their population in that first year of the program. Actually, through the work we've done together, we already found 19 early stage or pre-cancer situations that we actually caught early, intervened early to address, and those obviously saved cost for the plan, and also way better outcomes for the patients themselves when you can intervene that early. When we look at actually the cancer patients we supported, we have seen an 81% reduction in hospital admissions for the patients we supported ourselves compared to those who were not in color. And through our review of the treatment plan for those patients, 78% of them actually had gaps or recommended changes in the treatment plan that we implemented because we felt there's gaps in how the treatment plan was set up that was not aligned with what we think is the best practice care today, and we actually changed that. And 15% of those also had a medical specialty or site of care therapeutics opportunity change, and we went and addressed that with them and their provider. Those are the health outcomes we've seen and we identified. And from a financial standpoint, what actually this translated to in that first year is 23% reduction in their total cancer spend, like their total cost of care, when we compare the patients scholar supported compared to patients that were not. And this generated $3.1 million in net savings, net of the cost of the program, and a 5.1 to 1 ROI. So this is sort of the quick overview of the outcomes and of that first year working together. And it's driven by us trying to address all these 5 components of failure points I shared that we see today in cancer for you all. Let's talk about each of them and what we've done on each. I'm going to start with the first one, which, as I mentioned, one of the common things we see and drives high cost claims is a screenable or preventable cancer that was diagnosed late. And I'll share a little bit what matters here the most today for you if you're thinking about trying to address that problem in your program. To close the screening gap, there's a few things that need to happen really well. One, like any program you do needs to engage a large proportion of the population, because otherwise you won't move the needle on catching enough cancer early. And that requires a very engaging approach that meets people where they are, and it goes where they are. It also requires to make sure that we're removing and very proactively working on removing every single barrier for patients to actually get their screenings done. I typically say screening is a behavioral problem. It's not you all cover screening in your population, but it's really hard to get people to do the things they need to do. And actually, there's a lot of barriers for that. If you're a shift worker, you need to take off work. Probably you need transportation to where to go. It's not something easy. You need to make a bunch of calls to get your appointments done. So it does take work and effort, and that's something you need to address. The third thing that I'd flag too, and that's an important one, is in your population, there's people at high risk of cancer who don't know they are at high risk. And because they're high risk, they're more likely to get cancer, but they're also more likely to get cancer early. And they're not probably screening because they don't know that they're at high risk of cancer. And what's hard about those patients is you don't either see them in your claims data. If anything, they probably are labeled as low risk in your claims data, because they're probably just patients who are healthy. They just have family history that increases the risk of cancer, and they just don't know about it. If you don't address those, you're still going to be at at a problem, because they are likely the ones that show up next year in your claims, basically. So when we implemented that part of the program, what we do typically and what we recommend others do is like, we had to do a very grassroots approach to get everybody screened, like showing up in every manufacturing plant between shifts, covering all shifts, including the night shifts, so everybody can know about the program, thinking through how else we can communicate the program to the population through the managers, through the frontline worker leads basically at the facilities. And that allowed us to drive, a high utilization. So we were able to engage 20% of that population through this approach, which then that can translate to actual completion of screening. So, we increased screening adherence in that first year of the program by 65% among those who had a, who were due but did not get screened. And this was by closing the gaps for two-thirds of those patients who actually had gaps that we had to close. And that also translated to finding cancers early. And I'm also going to share one thing here on the importance of screening. You just don't find cancer. It's not just about finding cancer early. Today, for some cancers, you can actually find pre-cancer and then remove that before it becomes a cancer, which is like completely different impact on both outcomes and costs. So, a colonoscopy that removes precancerous polyps, or somebody who has a positive HPV test for cervical cancer screen, and then you go and remove precancer cells. So the impact here is not just about finding it early, it's probably also preventing it in some cases. And as I mentioned, because it's a clinical program and we have physicians doing the clinical assessment and working with the patients, there were 27% of the people who we supported who were at high risk of cancer or for at least one cancer. Some of them more, typically it's one. But what was important with those 27% is now they're getting managed better. They know about their risk, and there's guidelines of how you should be screened differently if you're at high risk of cancer that we also make sure those patients are on. And that also allowed us to make sure that they're tracked effectively. And some of those 19 actually were people who are at high risk, did not know they needed to be screened, and we screened them early and caught that early enough. So that's what it took to sort of deliver on that part and make sure that now you can close screening gaps and catch cancer early and prevent these high cost claims that could have been preventable should people got screened earlier in their journey. So that's the first one. The second one is, as I mentioned, sometimes the workup, we see that it's an insufficient diagnostic workup and it results in a suboptimal plan for the patient. I'll share a few insights here from what we see in our own data. If someone has an abnormal result, I think the most important thing is how you can very quickly get them to a diagnosis and then get them to a treatment initiation. Because with cancer, time is critical, and the more delays you have, the more advanced or the cancer becomes. And actually, if you look at the data, I think half of patients who have I'll give an example, half of patients who have an abnormal FIT test, which is a test you use for colorectal cancer screen, half of them do not get the right follow-up in traditional setting within the first 6 months after they learn about their abnormal result. These are patients who probably have cancer or need to be evaluated and don't get that result. So one of the things that's critical in this process is how do you make sure you're very hands-on the patients who actually are being diagnosed with cancer, so you can do the right workup, you can do it effectively, and you can do it quickly so they can start the right treatment quickly. And it's part of how we implement this part of the program as well, and that's what we did here. So we actually have an SLA of like within 24 hours following up and working with the patients directly whenever there is an abnormal result, and being very intentional with the team on how we actually get that patient to get their treatment workup done and initiate care with their oncologist so they get the right treatment quickly. And that matters a lot, and we see that in the claims data. For example, with this customer, we actually saw a 66% faster time to diagnosis for patients who were diagnosed through color compared to patients not diagnosed through color. And what's interesting too is for many of those that came to us with cancer and who had a workup done, for half of those patients, we've seen gaps in their workup, as I mentioned earlier, things like a missing tumor marker or a missing imagery that actually was critical for deciding on which treatment they should get or whether a surgery is warranted or not for that patient. And we closed these gaps. Those matter because, again, it's really those two things, like making sure you do it quickly so that patients can quickly be on the right treatment, but also making sure you're doing the right workup so patients are on the right treatment. That's an important part. It's an important component of the journey. It's also a very narrow one, right? It's really between when you get diagnosed and then when you start your treatment. It's important to focus on that if you want to reduce the number of patients with an insufficient workup and then the downstream impact of that. And in this case, that's the difference that it made for the patients that we actually supported. The third that we talked about is an ineffective or inappropriate treatment plan. And I'll share here also some insights that we're seeing from our own data. Again, I mentioned treatment is becoming more complex, and when it becomes more complex, the likelihood of misses happening is increasing, and we see that. We see that when we support our own patients on it. And the standard of care today and how you ensure patients have the right treatment in cancer is a multidisciplinary review, basically. And in major cancer centers, they do a multidisciplinary tumor board where they review the care of the patient and they make sure it's effective. It's also a standard by ASCO that, if you want to deliver great care, you should do a multidisciplinary review of every patient. What we do is actually what's been interesting is we scaled basically this multidisciplinary review model so that every single cancer patient who comes to us can get an expert medical opinion review and can get it continuously. It's not just a one-time thing. It's actually a core component of their care where at every single important decision point in their treatment, we're actually bringing in experts to provide the right input on the care of the patient. We have experts in every cancer. They work with the oncologist on staff who is treating the patient and supporting our patient. And they review these cases and to make sure that the patients are getting the right care all the time. And it's all the time because the decision points change with new information, right? Like you can do your workup, and now we have some information, and it informs the first treatment. Then at some point, you're looking at whether the tumor is shrinking or not, whether you had an impact of the chemo you've done, and then you want to decide if you want to do something else or surgery or radiation. That's an important decision point where, again, you need to make sure that you have the right input at each one of them. So we actually did that, and we believe we should do this for 100% of the patients, not just a subset, because treatment is becoming more complex across the board, and it's important that every single patient gets the right input, so they're always getting the right care. By scaling that model, now we can sort of guarantee or feel confident that every cancer patient is getting the right treatment at every point in their time, and it became standard of the care that actually every patient gets. For this customer, for the patients we supported, what's been interesting is first of all, 95% of them we found we had to do some change in their care. And those can be, vary from, symptoms that were unmonitored that we had to manage better for them, or, they were getting severe side effects related to their treatment, nausea and they couldn't eat well, and they were losing a lot of weight, which actually is a high risk if you're during treatment, and managing that with them and our own oncology dietitians to support this well, or mental health support because they've, the mental health impact of cancer has been high to them. But also, 78% of the patient had a meaningful change in the treatment itself, not just the supportive care, but the treatment itself. This is a regimen that we had to change based on what the workup was, or we did a workup that was missing and we find new information that actually should change what treatment the patient should get. I'll share an example on one of our patients in a little bit there. Dosing change or sequencing the treatment differently to manage side effects better and the outcomes better. And sometimes it went all the way to correcting a diagnosis for a patient. And you can see that this is big percentages, which again validates the point I'm making of there's a lot of gaps in the system. And today, we want to, and every customer wants to feel like that actually they have a way to guarantee that the right outcomes and the right treatment is given to patients. And we do have the tools to do that because, again, those are guidelines, evidence, expert opinions that actually you can make available to everybody no matter where they are. And the benefit of having a medical group is it allows them to make those recommendations real and implement them because, we have we can intervene better. We can intervene more proactively when we have a patient-doctor relationship to make a difference or to change it to address like a nutrition deficiency or address a symptom that the patient doesn't have, or even get a full view of the patient's journey and work with their oncologist on changing that. So again, it's a way to prevent these events from happening in the future. And in that case, it impacted a lot of the patients for the customer we supported. For the fourth one, unmanaged symptoms and absence of palliative care, I want to talk first about why this is critical. This is not just critical, again, from a good support for the patient. If those are not done well, patients are less likely to continue treatment. They're more likely to discontinue treatment. And there's also potentially like life-threatening and high-cost events that could happen, as I mentioned, like going to the ER or even the ICU because of unmatched symptoms. Today, there's actually really good standards of care about how palliative care should be delivered to patients and how this should be core part of the care of the patient. Again, it is a standard that ASCO sets for anyone who wants to be certified. The team and the medical group at Color does have palliative care experts. They work directly with the oncologist and support the patient in the journey. And it's pretty proactive. It's also checking in on the patient, before and after every key intervention, after their surgery or after their chemo or after their radiation. When you do it that way, you can now start better managing patient symptoms upstream and making sure that they're not intervening in the care and the outcomes of the patient in a way that also, as I mentioned, drives savings and costs at the end. In this case, when we analyze the claims data for our customers and compared patients who got support from Color versus who didn't, we saw a 90% reduction in ED visits. We saw 81% reduction in hospital admissions. And for those who went to the hospital, we've seen like zero readmissions to date, which also speaks to how when you're very proactive in the care and you have a very clinical first approach to supporting the patient, you can actually make outcomes happen and then prevent these high cost events from happening in the future. So that's an example of those. Again, both any of these events is a pretty high cost event typically in the care of the patient, and those are things that we've been able to support our customers on and reduce the impact of that. And again, it delivers much better care for the patients because they're able to continue their treatment, they're feeling better, they're also going back to work, etc. So it's an aligned impact both on the cost and the impact for the patient. Here's my last one, and that's also one I think that many of you mentioned in your survey is something that's actually you see very frequently. A very expensive treatment could be delivered at lower cost for your patient, and for many reasons it is not, or you see that, and it's pretty expensive and it's typically a high cost claim. What's interesting in this is actually when we look at the data, this is actually an important opportunity, and it can take different flavors depending on the patients and what you can do with those patients. Some patients you could probably move to a lower cost of care site. Again, it requires many things to be true for that to happen. It requires that they're not taking other drugs, they're stable, there's no risk of moving them. Some patients you can also we see that also a lot in our data. Some patients you could move from a brand to a biosimilar. I have many customers where actually we see in the data that 5 of the top 10 cancer drugs are brand drugs that have a biosimilar opportunity that was not being used, and so they're driving a lot of costs in those high cost claimants. Sometimes it's also about how you think about dosing and the mode of administration. If you have an injectable that you can move an infusion to an injectable that could be done at home, it's not just more convenient for the patient, it also actually lower cost for the plan. We typically see 50%, and in that case, we saw 15% of our patients of the patients for the customer had a lower cost treatment opportunity identified. We look at those consistently, and for every single one of the cancer patients, we evaluate their treatment, their medications, we evaluate those opportunities, and we see where there's a clinically appropriate opportunity to impact the cost. And if there's a clinically appropriate opportunity, that's how we intervene. And again, the benefit of making it clinically appropriate is actually it ensures that we get alignment from the oncologist on whether this could work or not, and then we make it happen. Those drive savings as well. On average, we've seen in that case $93,000 in average savings per patient. What I would say here also, the range is pretty wide. So you have some of them that could go as high as $200,000, $300,000 of saving, some that are actually lower. And so this is the average across all the patients, but typically we've seen wide ranges depending on the drug and the opportunity and what could be done or not. So that was the fifth lever. It's also something that you can instrument, and where by having a clinical layer, you can actually make sure that it happens, and it happens for the right patients, because not all patients can be moved. Many of them actually cannot. And sometimes it's hard to see that in the claims itself, but you can see it when you look at the patient's records, at the profile of the patient. And when it's appropriate, you can do that. And when you have a clinical layer and you're trying to make those changes, you can also ensure it's done within the appropriate clinical support for the patient. So if labs need to continue being done to monitor the patient, we can order those, moving the prescription, moving the records. So it's been a way to actually ensure it happens when we see an opportunity for our patients. So this is the overview basically, and for each one of those 5, and how we impacted the outcomes for our customer for each of these 5 key root causes that I've talked about at the beginning. I do want to share one example of a story of a cancer patient. There's actually a patient based in Texas for one of our Texas-based customers, works in oil and gas, has 2 kids, went to the ED for shoulder pain. And then when they did some imagery, they found a mass in the abdomen, so in their belly, and they were told that they had a pancreatic cancer. The day they got their diagnosis for pancreatic cancer, he came and basically had color as a benefit. So he booked an appointment with our team. We typically have very rapid availability to talk with our oncology team. So that, like, same day or next day. In this case, the same day, he was able to get an appointment. He spoke with our team. And the other benefit of having a doctor-patient relationship with our patients, because of the way we set up the virtual cancer clinic, we can not just request records from their facilities, we can also access them through the HIEs basically. And so once we establish a doctor-patient relationship, we get those records out so we can very quickly review them and find gaps for the patient. So we did that in this case. We got the patient's records and we ran our multidisciplinary expert medical review. What was interesting is we found that there's a tumor marker that actually was missing that actually could impact the interpretation of the diagnosis. Once that was done and then we got the data back, actually it turns out this was a misdiagnosis completely. So this was not a pancreatic cancer. It was actually a type of liver cancer that is called cholangiocarcinoma. They look the same except for one tumor marker that would look different, and in that case, that was not done. But the impact on the patient is major because it's a different prognosis. It's a completely different treatment regimen. We caught that actually like a week before they were supposed to start their chemo. They had their port already on. So we then worked with their oncologist to flag that change and why this is important in this case and intercept it before the patient started treatment. In this case, the oncologist was not, it was a community oncologist in this case. They were not, they had not seen a cholangiocarcinoma for a long time. So it was the first time they see one in their career since they did training. And so that's why they missed it. And what was interesting in that case too, that patient probably needed to be treated somewhere else where actually the treatment would have been where there's somebody specialized in the treatment of that type of cancer because it's a rarer cancer. So we work with the oncologist on adjusting the diagnosis, on getting the patient to the right place to get their treatment, and then make sure they get the right treatment. If you count all of the savings that this could have impacted, especially from like spending money on the drug that would not have been effective, that would have failed, and then have to switch to another one, etc., we estimate this has saved the plan $100,000 in spend just from that change at the beginning of the process. And also the other thing, again, like this is a completely different outcome for that patient with higher survival when rates and longer survival rates, and now they're on the right treatment that could actually extend that for them. So that's an example of how when you have that capability, you can actually now deliver care much better across all 50 states for your members and deliver through it better outcomes for your members and for you as on a cost standpoint. So that was one example I wanted to share just as a closeout. All right, so just to recap, for our customers I shared, our manufacturing customers I shared, this is again the impact, the program impact after the end of the first year. So a 23% reduction in the total cost of care, and this is based on comparing patients we supported to patients we didn't support, $3.1 million net saving in the first year. And again, if you look at what drove that is, again, engaging a large proportion of the population, actually, within cancer patients and survivors specifically, our engagement rate is much higher than just the overall population because we focus on getting those patients in and working and supporting them. A 5.1 to 1 ROI from this, and also a very high patient satisfaction from the support they've received in the program. And so it's an example of how you can actually today, and you have the tools to address the biggest drivers of your high cost claims in a way that is very meaningful to your bottom line, but also is much better aligned with great care and great outcomes for your members. And I say, like, you want your members to get the care that you would want for yourself and your family, and you can actually do that across all 50 states. And no matter what, your patients where they are, no matter how far they are from a major cancer center or not, no matter what cancer they have. And that also can be a way for you all to get much better outcomes and much better costs. I think you all filled that second poll, but I'll give it a minute if others want to add more. I had a second poll where I wanted to ask people, if you think about everything I shared and sort of the different buckets of impact across screening and catching cancer early, getting the diagnosis right, getting the right oversight and treatment, managing symptoms, and controlling the site of care. I'm curious where you see the biggest gaps today in your own uh, in your own strategy and in your benefit ecosystem and in your plan. All right, so I see it looks like it's pretty spread out mainly on the upfront part. 45% of you have been talking about the gaps on the catching and making sure people have the right diagnosis, and then it looks like, roughly 20 to 30% are on the rest. Okay, this is very helpful. And I think one thing again I would say is those don't need to be treated as separate problems. Again, if anything, you can see how a single program implementation can actually work to get all of those uh, to be addressed effectively and successfully. And that's actually an important way you can do that well. If anything, I actually do think as you think about your options and your solutions, addressing those five or having a more comprehensive approach to all of it and that's more cohesive actually makes a bigger difference because then you're not like patients like members don't get confused where to go and how to go and for what and for whom, and you sort of have one single accountable way to get that done. And it is not it requires the same sort of infrastructure or setup of like great clinical oversight and great clinical layer and great clinical management of the patient. So for what it's worth, there's definitely benefit in thinking about all of those five together as a solution. Um, I'll end maybe with the slide of the key takeaways, and then I'm happy to take questions. But if you want to think again about what to take out of this conversation, it's today you actually build your networks and you design your networks to optimize access and to optimize cost. And you continue doing that. And I actually do think most of you probably have a lot of solutions and coverage in the network that allows you to get that are lower cost or that are optimized for access or for expertise. Because that's like what you have to think about for all of the conditions you support, not just cancer. Uh, what is interesting in cancer is because it is a very complex solution, complex care and complex condition, actually, sorry, because it's a complex condition, the problem of cancer cannot just be solved by like having a different network design. If anything, it is clinical decisions that happen that actually have high impact on the costs and on the outcomes of the patient. And that's why I typically share like the way you can address it is by thinking, how can I bring that clinical accountability to the plan and to the plan design I've done already that already have all the tools I need to make sure patients have access to the right expertise, etc. They just not being used effectively or compellingly, or again, sometimes you cannot solve for access in a remote place to the best expertise. So that's a benefit of that. That's what I share as a takeaway. Like think about this as if you have the right clinical accountability, you can actually lower your cancer spend and you can actually impact your cancer spend. And these are the three things, that get you there, like making sure all members have the quality care that you want for you and your family, and building a program that's actually engaging and trusted so that it's actually used by your members and used at the right time by your members. And that when you do that, because then you can optimize and then you can actually drive better outcomes and lower costs at the same time. And those are the costs that actually you're trying to move in your system. So those are my three sort of takeaways to wrap this up. And I think the last thing I'll share is if any one of you wants to try the program or people who may need the program because they're in the hard part, we do have this available at no cost. So if you go on that QR code here or the link, you can access the program yourself. You can also make it available to anyone who actually may need help during treatment or is in a bind or needs support. So we'll leave that. It's going to be also in the backup, but feel free to use it. It's something we do both for you all to get an experience of it, but also because sometimes people need it.
Danny, we probably should take a look at some of the questions. There aren't very many.
Let's go through
So the first one is about the offering of the program through a health plan, or maybe a little detail on that.
Yes. I can answer that first question, Abby. So yeah, the program can be offered across health plans. So typically we have customers, offering it for all of their members on any of their health plans typically, and we can do that. So that's fine. On whether it's the onus on the employee to enroll or whether we can do our own outreach. We do both. We can do claims-based outreach. We do campaigns and activities to reach out ourselves to employees to make sure they know the program. One thing I would say that's interesting in cancer is that patients are at different parts of their journey. Some of them just got diagnosed, some of them are in ongoing treatment today, etc. But that also means that where they show up in your population can differ. Some of them may be going on disability and working with your disability vendor to be out. Some of them may be telling your manager they got diagnosed and they need help. Some of them come to the HR team. Some of them are already getting treatment. Some of them are probably using some of your other benefit solutions, like your mental health solutions. When we implement together, we make sure all of these places where we know people may go know about color and are aware of color and have the assets because that's where you want to catch them so you can actually make sure they get the right treatment. So we do both proactive, well, I would say proactive outreach when we find them. We do a lot of campaigns to make sure people know about the program so they can also come to us. But also we work intentionally with our customers on where we think patients may need color and where they would go and make sure in those places there's enough information so they can actually use the program.
Okay,
Uh,
the next question is actually pretty interesting. It's about the
yeah.
95%, 78% of your quotes that you had. I guess if I had answered your poll, as we weren't, we didn't as kind of the moderators here, I guess I would have said late diagnosis, but as being one of the key areas of managed that employers can actually manage very effectively. But then number three, the ineffective treatment plan needing the multidisciplinary expert medical opinion, which I think is fantastic, what you guys are offering. Um, sounds like that would be really important to make sure that the patient is getting not substandard care, but the right care. And then the last point that this question was about the difference between community-based or academic
Yeah.
setting. We just had a cancer care program out in Midland, Texas, if you can believe that, a rural healthcare center. And one of the big issues that we discussed there was about between the access to high quality special cancer care in Dallas Fort Worth. Of course, we have lots of that available. And out in the far west where the oil workers, which was your example, is working, how what's I think, how would you respond to that about the dramatic difference?
Yeah, no, it's a great question. I would
Yeah.
say it is so a few things. One, let me start maybe with the second one because I think it's a bit easier. There's definitely differences, obviously. Like if you're in an academic setting, you probably have better access to expertise in community setting. I would flag that probably 80% of patients are not in academic setting, they're in community setting. And so in a sense, that's still a gap. What is interesting with academic setting is like you still, I think where we still see gaps or needs is on things like, are you getting the right mental health support? Are you getting the right dietitian support? Is your caregiver supported in the journey with you? There's still a lot of those gaps we see. Even with symptoms, sometimes we've seen gaps where, patients are not getting their symptoms managed effectively. I actually will share an example. That was in an academic setting, a patient who had was ongoing treatment. They came to us. They actually told us they fell 3 times in the past month. It was actually due to a very severe side effect of their chemotherapy. It wasn't even in any of the chart notes from the patient from their setting. And I don't know if they mentioned it or not to their provider or not, but it was critical because now it's a high risk, fall and breaking a hip and going like there's like a lot of risk of people of that side effect. And we had to manage that. That's an example where it wasn't an academic setting. I think it's a function of also the system moving fast sometimes, where like you go speak with your oncologist for 15 minutes, we're focused on getting your treatment done because that's the most important thing. We want to shrink tumor. And so you still see things mix. So I would say it is less a reflection of care being substandard. I think back to your first question, I think what happens is because cancer journeys are so unique and cancer is so complex, and the system today is pretty fragmented traditionally, like cancer sort of magnifies that fragmentation because you have so many components of the care and nobody is like thinking about all of that. And so every one of those like patients that we shared, like the 95 and 78%, there's not one single common thing that we change or found differently, right? Like it's very different by patient. It's very bespoke. It's very unique to their own situation. And just that doesn't happen today. But I think sometimes providers assume other people are doing the job, but it's not, or it's taken care of somewhere else. Sometimes it is actually a truly misdiagnosis, like the examples I shared. Sometimes it's more nuanced, like the fall example I just shared. So the variation in situations is pretty big, and it's hard. And I think part of the thesis is like actually, if you have a virtual model this way, you can standardize the failure risk, that like these things that could go wrong in every case, and make sure you are checking against them so you're not, they don't go wrong. But so I think it's more a manifestation of the speed of the treatment innovation and complexity, and the complexity of cancer, and just the traditional setting and how it's set up today not catching up to it, that like things fall through the crack even with the best intention of everybody, because everybody has the best intention and everybody wants to give the best care for everyone. It's just if you get two new drugs for every like for breast cancer in the past 2 months, and then another three, like another drug for pancreatic cancer, another drug for multiple myeloma. Like in the past 2 weeks, there's a new drug for multiple myeloma. There's another new drug. There was like last month, there was one for breast cancer. There was a new one for pancreatic. The pace is pretty fast. And so again, think about how you want to flow all of that in your practice as a clinician. There, you can see how things could fall through the cracks. But a virtual model can help solve that because you can make those standard of care and just follow them much better.
Interesting. Well, we're about out of time, but I just want to mention one thing I had mentioned about our especially symposium that we have on September 23rd, and for all of those who are still participating in as listening into this program, the 5 root causes are so interesting. I'm so glad you outlined them and discussed each one, because each one of those is going to be discussed during the symposium, starting with the prevention and early detection, the care coordination and centers of excellence is a session, the precision oncology and personalized cancer care is a session, managing oncology costs while delivering high value care, and then employer leadership roundtable after that. It's we didn't know about your 5 root causes when we put this together in the symposium, but it addresses each one of those. So for those who are listening in, please register for the symposium on September 23rd. It is an afternoon program, including lunch at first. And if you're an employer member of the Dallas-Fort Worth Business Group on Health or the Texas Business Group on Health, you are welcome to attend complimentary. So anyone else, give us a call and we'll help you out. So Danny, thank you so very much for your discussion today. It was very, very good. And thanks for putting the slides together. It's pretty compelling information. Really appreciate it. And thank you to our sponsors, Color and Genentech and Merck and Pfizer and all the other ones. We really appreciate the support for this. It's a great program.
Thank you so much. And I hope this was helpful for those who attended. So I appreciate it.
Okay.